Somebody wanted to know about CAOS, but it's not CAOS with an H, but CAOS, which is cerebellar ataxia and areflexia, as well as optic atrophy and sensorineural hearing loss, And this is a childhood disorder, so the onset of symptoms is in infancy or childhood. And so it's very characteristic because you have multiple recurrent bouts of progressive neurologic deficit that occurs in childhood. And the reason it matters to me is even though I'm in an adult hospital, it can come to me and look like multiple sclerosis or some other relapsing remitting neurologic disorder because it comes and goes, it's intermittent. But the key and differentiating features are its onset is in childhood and it's bilateral optic atrophy and bilateral sensorineural hearing loss. And that's super important because the strategies for gene testing have changed. And if you're in a center that has genetics, it's so easy, you can just refer there. But if your center's like my center, it takes a long time to get in genetics. And so we have to actually do all the genetic workup and then send the patient to the genetics. And so it's a spectrum of disorders and it's a spectrum of workup. So if we know what the phenotype is, and the phenotype is very specific, then we can do targeted gene therapy. We can just go straight to that gene because it's cheaper and it's faster. However, if it's in a spectrum of disorders, then you might have to do the panel. So it'll be like an optic atrophy panel or an ataxia panel or a hearing loss panel. And if you still don't, you think it's genetic, but the panel and the targeted were negative, then we have whole exome and whole genome, depending on whether you want to include the coding sequences or just exons or exons and introns. And so this is the spectrum of normally how we do the genetic workup on the clinical side. And normally you just go in order. However, sometimes you got to go backwards. So in someone who has optic atrophy, the optic atrophy panel is going to include the common optic atrophy things, OPA1, labor hereditary optic neuropathy, Wolfram, the common things. Same with the ataxias. There's going to be the spinocerebellar ataxias with numbers like 3 and 7 and 1 and 6. But when you have the combination of cerebellar ataxia, optic atrophy, and sensorineural hearing loss, we can go backwards and do the targeted again. And the targeted is for CAOS because we have that gene, ATPA13. So it's not important that you know about CAOS. What's important to know is we can go forward in the genomic strategy, we can go backward. We're not committed to doing whole exome or whole genome. If you've done the panel, try and make a single unifying diagnosis. And in the past, we'd have to look in the Mendelian inheritance or man, but now we have the internet. And so you just put in cerebellar ataxia, optic atrophy, and sensorineural hearing loss, genetic, childhood onset, the first thing that comes up is CAOS. And if you add pes cavus onto there, this arched foot, that's capos, but it's the same gene. And amazingly, this gene has different phenotypic expressions. And so sometimes it's rapid onset dystonia and a Parkinsonian-like thing, and sometimes it's alternating hemiplegia of childhood. And so you need to know a little bit about the genetic testing strategies, whether you're going to do a targeted, a panel, whole exome, or whole genome. You have to be able to go backwards sometimes. And if you have a single unifying diagnosis, Google knows.